Everyone, we are just about to get started. Menopause and sexual desire tonight for our Instagram Live. I am just waiting for my guest, Dr. Kyle Stephenson, to join and bring all your questions, anything related to menopause and sexual desire. We are excited to address. Just logging in again. Hi, Kyle. How are you?
Good. How are you, Lori?
Good, good. Great to have you.
Yeah, thanks for having me.
We are talking about all things menopause and sexual desire tonight. It's a very popular topic, one that is coming up quite a bit recently in the media, with good reason. We know that menopause impacts half the population, and it's something that is inadequately studied, inadequately researched, and people leave with a lot of questions that they take to their healthcare providers. And it's just a really good time for us to be having this conversation about menopause and sexual health.
hmm
Yeah.
Yeah. Yeah, so I'll just quickly introduce myself for folks that haven't been on here before. I'm Dr. Kyle Stevenson. I'm a clinical psychologist and professor of clinical psychology at Xavier University in Cincinnati, Ohio, and longtime collaborator of Lori.
Excellent. Yeah. And for those of you who I don't know, I'm Dr. Lori Brotto, professor of OBGYN, University of British Columbia in Vancouver, and a licensed psychologist. And this is our third Instagram Live series. And let us know if you want to hear more. Our intention with these Instagram Lives is really to take some of the science, distill it down to the key facts and key messages, and share it with you all. And of course, listen to your questions so that we can address them. This is really about knowledge translation and ensuring that people have access to the best, most accurate, evidence-based information possible.
Yeah, there's plenty of information out there. Not all of it is high quality as you'd like, but so we're going to go back and forth, and I'll just kick us off, Lori, with a question for you, if that's all right.
Sounds good.
So a lot of people, as you mentioned, half the population going through menopause or perimenopause notice changes in their sex life, but they don't know what's normal. And so if you could just tell us a bit about what's actually happening, not just with hormones, but with other changes, physical and otherwise.
Yeah, excellent. Yeah, so turns out a lot is happening. First of all, perimenopause is the period of time when estrogen and progesterone are overall declining, but it's quite an erratic change where there may be days where estrogen and progesterone are rapidly increasing and then decreasing again over the course of the perimenopause, which can last up to 10 years.
hmm
We see an overall decline in those two hormones. Menopause is a single day that is defined as the day after 12 consecutive months with no period, unless, of course, there's been a medical reason why your ovaries are no longer working. So the ovaries have been surgically removed, or maybe chemotherapy or radiation therapy have led to the ovaries no longer working. So that's menopause. Postmenopause, of course, is from that day through to the rest of your life, which we know, given extended life expectancy today, can be 30, maybe even 40 years of a person's life. So what actually is happening during that period of time, and why does it impact sexual function? So as I mentioned, estrogen and progesterone erratically changing. Some refer to it as a zone of chaos, but overall there's a steep decline until postmenopause, of course. And we have estrogen receptors throughout the entire body, on all the major organ systems, the brain, the lungs, the blood vessels, the vagina, the vulva, everywhere. And so when you think about these hormones declining, it means any organ system where those estrogen receptors are located can be impacted. So specifically when it comes to the quote reproductive organs, we think about the vulva, the vagina, those can be directly impacted. So with less estrogen present, the vagina, the walls of the vagina become less elastic. They can become drier. The
hmm
walls can become thinner. And of course, this gives rise to pain. So dryness first and then vaginal pain. That means that any time that a person attempts to insert something into the vagina, in sexual activity or otherwise, it can be quite painful. So it can be a sharp shooting burning pain, or some will even describe it feeling like there's even razor blades at the vagina. So
hmm
really, really, really painful. Medically, this is called genitourinary syndrome of menopause. I'm sure listeners have, if you've been tuning into social media, you may have heard this being referred to as GSM. And it's basically the constellation of different vaginal and urinary changes that happen. So there's that direct effect on sex being painful. But if you can imagine, if something hurts, your motivation for that thing is going to go down. And so this is how the hormonal changes with menopause impact sexual desire. And it's through the fact that sex becomes more painful. So that's kind of the most direct route. And then there's all of these kind of indirect routes. So sleep disruption, which affects a huge number of perimenopausal women. So waking up in the middle of the night due to night sweats. So those are hot flashes in the day. We call them night sweats when they happen at night.
Mm-hmm.
They lead to very disrupted sleep. And that, of course, can directly contribute to changes in sexual desire, changes in mood. So, new onset or a recurrence, which means you've had a depression in the past and it comes back with perimenopause, can impact up to 70% of women. Anxiety, irritability. You can imagine you're not really into sex if you're feeling irritable or your mood is down or you lose interest in the things that you typically enjoy. And then there's changes in body image. So, well documented changes, again, as fat distribution changes because estrogen production goes down, can impact a person's sense of self and body image and all of those things. So we sort of have this collective of hormonal, physiological, psychological, relationship, and those can all affect sexual desire.
Yeah, it can be so tempting to just try to boil it down to one thing, but nothing that's going on in the body is disconnected from everything else that
Right.
goes on in the body that affects the context. So yeah, really,
Yeah.
I hear you describing this perfect storm.
Yeah, it's a perfect storm. Yeah, only we don't enjoy it very much. So it's an imperfect storm of sorts. Kyle, let me ask you a question. There's often an assumption that sex becomes less important. It's kind of a stereotype, if you will,
Mm-hmm.
with age. Where does that idea come from,
Mm-hmm.
and why can it be harmful?
Yeah. So, I mean, there certainly can be a kernel of truth because, as you just described, there's so many of these changes happening that you need to sort of redesign how you're coping, how your relationships are. But also, I think an even larger part of it is really just a sense of ageism, the stereotype where older midlife and older women are simply not represented in the media as sexual beings who care about and enjoy sex. Think about how many movies, TV shows you've seen with a woman who is both coping with perimenopausal or menopausal changes and still enjoying sex and still talking about it and caring about it. What you generally get are young, also, white, able-bodied, thin women, basically, that are the representation of when
Yeah,
sex is important, when it's pleasurable.
yeah,
So what that can do is it can really be internalized, even if it's not something that you agree with, and even if you know from your own experience that sex matters, it can start to feel like it shouldn't really matter, that all of these other things are more important, and it really can get pushed down the priority list. It can be the last thing that you feel motivated to address. And that can be harmful because sex does matter. We have lots of great studies about how women at all ages can and do value sex. It can serve as a source of so many positive things, from pleasure to relationships to overall health. And that at all ages, you can have these concerns. You can have low desire, as you just talked about, vulvovaginal pain, difficulties reaching orgasm. And when these problems come up, not only can women themselves feel like I shouldn't really prioritize these are not important, this is not my area, but
hmm
also the healthcare system. I mean, you have healthcare providers of all sorts, who are not really trained in these areas and may not be any more comfortable talking about them than their patients are. So they
hmm
often don't get asked about, especially when that lack of comfort is combined with the stereotype. So
Right.
you have sex being important and potentially this source of great things like pleasure, happiness, connection with partners, but instead it just becomes the source of sadness,
Yeah.
shame, frustration. And so, this is so important what we're doing here, and more generally with you and I both doing this work, is really trying to talk about this to normalize it, because in the absence of broader discussions from sources like the healthcare system, and because there's still the stigma about talking about it with people in your life, um, someone needs to talk about it to normalize that
Yeah.
this is happening. And so really trying to get the message out there and to create and also make accessible evidence-based ways of helping with these problems is, I think, really key.
Yes. Perfect segue. Last week, you and I, on our Instagram live, which was focused on the mind body connection. And for anyone who's tuned in that didn't get a chance to watch it, it's saved on our eSense Instagram handle. It's also saved on our eSense YouTube page. The whole conversation is there. You and I have spent the last several years working together on really helping to close that gap. Given what you just talked about, that there are evidence-based treatments, but there's still such a massive gap in people in general, women in particular, accessing those treatments. And that's why we came together to kind of brainstorm and puzzle through and then build what we could in this space of bringing evidence-based psychological treatments out to women with low desire, women and gender diverse people with low desire,
Hmm.
hence eSense. So maybe say a little bit more, Kyle, about how eSense addresses what you were just talking about, which is,
Hmm.
the ageism, the assumption that
Hmm.
sex ends at a certain age.
Right.
How is eSense addressing that?
Right. I mean, on a really basic level, eSense talks about sexual concerns and also sexual pleasure, sexual excitement, sexual fun, in a very normalizing, non-shaming way. It assumes that women of all ages can value and prioritize sex, and is clear-eyed about these stereotypes that stop that from feeling like a maybe a natural, comfortable thing to do. I think it's also been created because these treatments are not brand new. I mean, these are sort of gold standard, scientifically
Hmm.
tested treatments, but they have been historically housed behind these walls of these systems
Hmm.
where to access them, you need to, first of all, be lucky enough to be in a geographic region where they're available, have the income, but also just have the comfort to really get through usually multiple layers of providers and dead ends and still sort of
Hmm.
maintain your motivation to seek out these treatments. So that's really difficult when it is the just sort of baseline discomfort is compounded by these stereotypes of like, well, am I really the type of person that should be prioritizing this, that for sex, for whom sex is for. And so eSense is created really just to be able to come directly to folks. You can sort of bypass a lot of those barriers that are present in the healthcare system and just within ourselves, this discomfort, embarrassment we have. And so you can get access to good evidence-based information and really specific suggestions for what you can do to relate differently to your thoughts, your behaviors, your emotions surrounding sex, which are connected to these hormonal changes and these social changes that you just talked about,
Right.
and really get that information and try it out in your life in a way where you have as much support as you want. Do it completely self-guided or have some human support along the way, really just to find
Hmm.
the way in which you find a place where you are pushing outside of your comfort zone, but
Hmm.
still in a place where you feel like you can really engage in these interventions.
Yeah, awesome.
Yeah.
Awesome. So, folks tuning in, you can feel free to follow what we're doing with eSense on the Instagram handle, eSense Health. And when we post this live, we'll put some links in there. There's a website as well, esensehealth.com. But
Yeah.
let's get back to the topic of menopause.
Yeah. So, this is related to what we were just talking about, but it'd be great for you to chat about what tends to happen during menopause and perimenopause, when those sexual concerns don't get addressed. So, effects on confidence, relationships, connection to body, things like this.
Yeah, yeah. And as you've just said, I mean, we're lucky if we address menopause in our
Hmm.
healthcare. We're even luckier if we're addressing sexual health in the context of menopause. So the reality is that when those sexual concerns don't get addressed, either by seeing a healthcare provider or somehow getting access to the right information and help. The impact of those problems doesn't just stay confined to sex. It spreads to
Mm-hmm.
many different aspects of a person's quality of life, their relationships, their kind of sense of themselves. So the first thing that might happen is you avoid sexual activity. And it's not just sexual activity that you avoid, and understandably, you might avoid it because sex hurts, but it can eventually spread to really all kinds of intimacy. So we often hear clinically people saying to us, it's not just sex we're no longer having. We don't kiss anymore. We don't hold hands anymore. I don't undress in front of my partner anymore. In fact, I try and go to bed at a different time from my partner. And when we
Mm-hmm.
really kind of dig into this, it's because people are so afraid that might then lead to sexual activity, which is uncomfortable, painful, unpleasant, not pleasurable for them. So a partner on the receiving end might have their own questions about, what does this mean? Are you no longer attracted to me? Are you rejecting me? Are you no longer in love with me? And it may seem like this is a bit, catastrophic in a way, but in the moment, real time, partners will say that it really is felt like a rejection.
Mm-hmm.
And then of course the person themselves with low desire in the context of menopause feels terrible because they really want to still be engaging in physical
Mm-hmm.
intimacy. They want to be holding hands. They want to be kissing. They want to be able to lie beside a partner watching a movie, but they're just so afraid that this might lead to sexual activity. And then there's also the added layer of just less energy, more physical discomfort. Again, if there's been sleep disruption associated with hot flashes and night sweats, if there's been more anxiety, if there's been heart palpitations, all of that is happening at the same time. So really nothing's happening in isolation.
Mm-hmm.
And we know that this connection is really real, that
Mm-hmm.
sexual health is directly connected to sleep
Mm-hmm.
in both ways. So there's some
Mm-hmm.
evidence that when we have better sexual satisfaction, we tend to sleep better. When we sleep better, we tend to have better sexual satisfaction, and many different facets of the stress response system as well. So for a lot of people in perimenopause, their stress reactivity increases, which means that it takes less to set off a stress response, where people say they feel stressed, they actually
Mm-hmm.
feel physically in their body the fight or flight system kicking in.
Mm-hmm.
And that can also hormonally directly contribute to changes in sexual function and sexual desire.
Mm-hmm.
And so we kind of get into this feedback loop where the
Right.
sexual changes affect the menopause symptoms affect the sexual changes. It's that domino effect that we talked about
Mm-hmm.
earlier. But unless we address it, and part of addressing it, of course, is getting information like this. So
Mm-hmm.
when we come into this space and we name it,
Mm-hmm.
then people automatically feel like, oh, okay, I'm not broken. I'm not alone. This is a well-studied phenomenon that's happening. And then with that, they're sort of positioned to then get help and ask for
Mm-hmm.
help.
Yeah. And just to put a plug in and underscore what you're saying about partner interpretations as well is, women themselves know often a limited amount about what's happening about menopause. And also in heterosexual cisgender relationships, partners can know even less.
Yeah.
And so that question of, are you not attracted to me anymore? Do you not love me anymore? You can get some frustration too
Yeah.
of, this is not about you.
Right.
you what this is and you can get this cycle within a cycle
Yeah.
of, that you can have the woman does want to engage, does want to be sexual, but is so frustrated by the partner's distress,
Yeah.
and then hard to respond to that as you would like to.
Yeah. Yeah. But for anyone who's just tuning in and might hear this kind of very dismal situation, um, don't worry. We have skills to address. I mean, this is exactly the kind of thing that psychologists and sex therapists are trained in. Like you and
Mhm.
I spent years of training, not just learning about sexual health and sexual function, how to improve it, but in the context of a relationship where everything is amplified. How do we address this? So yeah, I really want anyone who's tuning in to not feel despair if it feels like, oh my gosh, this cycle's just going around and around on a hamster wheel. Sometimes having an outside expert be able to identify what's happening can help slow down that hamster wheel, and eventually you can get off and find new patterns.
Yes, for sure.
Yeah.
Yeah. So Let me see.
Oh, yeah. Should we talk about providers, or maybe I'll ask you a
Yeah,
question,
no, no,
Kyle?
I
Yeah.
can, oh, I think it's a good follow-up. So,
Okay.
certainly we've already talked about, both you and I, about how often providers just don't ask, right?
Yeah.
They don't think to ask, they don't know to ask about sexual concerns. But that, and in addition to that, what do providers often miss or get wrong when they talk to midlife patients about sexual health?
Yeah, yeah. So, I mean, this is a question that's been asked many times in different research settings around the world in different countries. And the reality is when it comes to primary care, so your general practitioner, your primary care doctor, have received, to no fault of their own,
Mhm.
if they're lucky, maybe a few hours of training in sexual health, and so they simply don't know the questions to ask. They might be having their own embarrassment. How do I bring this up with a patient? And of course, patients themselves, especially women and gender diverse people, are reluctant to bring this up. So that's part of the problem. And yet women seeking help for menopause symptoms really want to talk about sexual health. And so someone needs to ask, and we would advocate very, very strongly for a two-pronged approach. So for women going through menopause to be able to say something like, and I've also noticed changes in my sexual health, as one way of opening the conversation, but
Mhm.
also healthcare providers to just make it a standard part of your practice, in addition to asking about vasomotor symptoms and mood changes and word finding problems and frozen shoulder and GSM and all of the other many symptoms of menopause, is to also ask, have you noticed any changes to your sexual health and your sexual desire in particular? So GSM, those genitourinary syndrome of menopause changes, might be more likely to be asked upon,
Mhm.
because maybe they're seen as more medical, but whereas sexual desire is often not brought up at all. So we really want to advocate again for everyone to recognize that that sexual desire and sexual health is health. It's a part
Mhm.
of overall health. And I think once we really embrace that it is part of health, we might feel a bit more confident to bring it up. So if anyone again is tuning in, sexual health is health. That's the biggest message we want you to walk away from this Instagram live with.
Mhm.
So let me ask you, Kyle, and you had talked about eSense on my last question to you. And we know, as you said, it consists of these really well studied, really well supported treatments. So cognitive behavioral therapy, we call it CBT for short, and
Mhm.
mindfulness based therapy. Sometimes we refer to it just as mindfulness. Say a little bit about how these two treatments, which maybe people think about in the context of depression or anxiety,
Mhm.
but how do they address sexual health in menopause?
Mhm. Yeah, I think actually a great segue into that is what you were just mentioning a minute ago, is once you really start to look at these cycles about how sexual health gets intertwined with all these different aspects of physical health and mental health and relationships, there can be this urge to say, this is too much, this is hopeless, this is overwhelming, I'm going to tune out, I'm going to back away, I'm going to avoid. And cognitive behavioral therapy, CBT, and mindfulness are both, I think, different ways of addressing that initial urge, which makes all the sense in the world. If you're having, repeated negative sexual experiences, you're worrying about it, you're distressed about it, the natural human response is to want to get away from that.
Yeah,
But these are two really good evidence-based ways. I mean, this is why we built eSense the way that we did, is we took the gold standard approaches and we tried to translate them into this online program. And there's a lot of overlap between them. They both deal with psychological processes. They both have a lot of the same effects on things like confidence, to be able to shape one's sex life how they want to have better interactions with partners, to really understand better what could go wrong and what can go right sexually. But they do certainly look different on the ground. And so for CBT, really a lot of the focus is on noticing, challenging, and then changing thinking and behaviors surrounding sex. So we can just use an example on the thinking side. If you could have, say, a postmenopausal woman that is experiencing vulvovaginal pain, and certainly part of the trigger for that could be these hormonal changes that you talked about, right? This is a very common experience. And that doesn't exist in a vacuum, right? When you experience that pain, that sort of razor sharp sensation during sex, you tend to get a lot of consequences from that. And those can be emotional, they can be more thoughts, and they can be behaviors. So emotionally, you can feel understandably anxious and afraid about the
Mm-hmm.
pain getting
Mm-hmm.
worse. You can feel embarrassed. You can feel hopeless that this is just sort of how things are now, especially when you layer on top that stereotype of, well, sex is not. This is
You're too
not
old. You're too old
exactly
to have sex.
right. Exactly.
Yeah. Yeah.
And so that can then cause a bunch of additional thoughts like that, right? Of more general thoughts
Mm-hmm.
about what is for me and what is not for me. And then also these behavioral urges, like, how can I just help my partner reach orgasm as quickly as possible to be able to end sex? And none of these are wrong responses, but they also don't tend to improve sexual problems.
Mm-hmm.
And so, part of what would be done in the context of CBT is to really, first of all, dig down on what those thoughts are, the underlying beliefs and assumptions that people have about themselves and about the world, and then to really sort of put those on trial almost, not somebody else
Mm-hmm.
deciding whether your thoughts are correct or not, but really you as an individual deciding based on your lived experience and your values whether these thoughts really make sense for you. So
Right.
this thought of, maybe sex is just for my partner, or I'm too old to be having sex now, this shouldn't matter to me, in big quotations. That's really getting at a lot of assumptions about who sex is for and who sex
Mm-hmm.
is not for. And then if you can unpack that and say, wait a minute, who is it that decided who sex was for and who sex was not for? And
Mm-hmm.
that can sound like a silly question because obviously there's no person, in an office somewhere making this decision. But the reality is that we walk around with these assumptions, and they
Mm-hmm.
they feel so automatic and they seem to be the way things are. And so if we don't challenge them ourselves, they get to just sneak in under the radar and take
Mm-hmm.
control of those emotions and those behaviors.
Mm-hmm.
And so you can, just by stepping back and evaluating them in this way, and then thinking about, what does this belief get me? Like, what are the
Right.
benefits for me holding this? And then
Yeah.
what are the costs? So potential benefit to those types of beliefs could be, well, if I'm thinking the sex is for my partner, then they do get the focus that actually they may enjoy that to some degree. That may help me avoid conflict with them.
Mm-hmm.
So there usually is some way in which these thoughts are giving a benefit, but it's often outweighed by the costs, right? Because
Yeah.
if you're engaging in sex and it's not pleasurable, and it's not fun, you don't actually feel engaged, then you're sort of training your body to approach sex as a chore or as a potential source of threat. Um, so CBT involves sort of more direct challenging of those thoughts, and mindfulness really involves bringing a specific quality of non-judgmental attention to those thoughts. Um, and so, let's take the same situation where you have a postmenopausal woman with vulvovaginal pain, noticing that pain sensation exists, and then the whole cascade of consequences from that.
Right.
Of that pain causes a further tightening of maybe pelvic floor muscles and muscle tension throughout the body.
Right.
It creates a really intense focus on the pain to monitor: is it getting too much to handle? Is it not? Um, and and then this whole secondary set of thoughts about, like we've just talked about, is, that this is connected to my broader sense of dissatisfaction with how my body is changing. And if that's all going on, you're probably not engaged with, let alone enjoying, sexual activity. So mindfulness is really about cultivating this ability to notice all of these things happening,
Right.
but similar to CBT in some ways, to take a step back and notice that those are products of the mind. Those are things that your brain is doing, and that you actually do have some say of whether you take those and follow that urge to
Yeah.
disengage or to avoid, or whether you allow those to exist and then mindfully choose a re-engagement. And that doesn't magically get rid of the pain or the discomfort, but it
Right.
could help you
Right.
have experiences that discomfort and pleasure can both exist simultaneously, and that there are just so many different aspects of your experience, and that you do have some control over where that attention gets pointed. So
Right. Right.
I could go on and on about these
Yeah,
things, but
yeah, great. It's a
yeah.
great. I think there it continues to be a lot of mystery around like first of all, what is sex therapy? What is
Mm,
CBT? What is mindfulness? But you gave some really clear and very common examples of exactly how these two complementary but somewhat distinct approaches can address. And you and I agree with the very, very strong evidence in support of vaginal estrogen
mm,
for a lot of GSM symptoms. So the idea with eSense, with either one of these, CBT or mindfulness, is really about kind of, a complement to
mm,
standard menopause care that would probably include vaginal estrogen if the individual has symptoms of genital urinary symptoms of menopause, like dryness, urinary tract infections, incontinence, other symptoms in the
mm,
vulva or vagina. So eSense is really a complement to. It's about making sure that the toolbox is full with the best evidence-based approaches to
mm.
optimize sexual health in menopause. And that's why it's so fun to be doing this work with you.
Yeah, agreed. And as the partner of, somebody experiencing some of these symptoms as well, is I just want to put a plug in that the medical interventions can be so powerful, and
Yeah,
they stop at the edge of the person, right?
right,
And that
right.
some of these psychological interventions really can include
Yeah.
the partner in a way that is hard to do through medical intervention alone.
Yeah, yeah, exactly. Yeah, perfect. Some of the comments are coming in just sort of validating what we've been seeing just about the prevalence of low libido years before GSM and pain.
Mm,
Excellent point that one of our viewers made. And that's why we really need this kind of holistic approach about, bringing the different multidisciplinary people to the table to make sure that the person who's experiencing symptoms has the best possible care
mm.
that they have. So let me just see if there's any last comments or questions. Not at the moment. So Kyle, we are out of time. That
Goes
flew
by so
by.
fast.
But for again, anyone tuning in, I think some of the key take-home messages are that sexual health changes during perimenopause and in postmenopause are real. In fact, we didn't address it here, but of the many different changes, menopause symptoms that happen, it's the sexual health changes that are not confined to perimenopause, that they can continue well through postmenopause,
Mm,
if not adequately addressed. Whereas things like brain fog, night sweats, hot flashes, other symptoms, for the most part, tend to be confined during the perimenopause or within a couple of years of postmenopause. So glad we're having this conversation. I really hope that we have empowered anyone who's tuned in, whether you're a healthcare provider, whether you're a person with lived experience of menopause symptoms. Please talk about these symptoms, get educated about them, talk to your healthcare providers. We also would encourage anyone who's interested in learning more about eSense to follow us. Our website is esensehealth.com. That's where this digital tool that Kyle and I have developed is right now available in a commercial pilot. We're looking to have it widespread commercially available in the coming months or so, certainly by 2027. And also let us know what else you want us to talk about. I think we've gotten Kyle onto the Instagram Live bandwagon. So thank you for that, Kyle. It's been an awesome conversation.
Yeah, and Laura, you've done this work for so long and made such an impact here. I'm just happy to be a part of it, and just want to say again that we do this to get these interventions out there so that they can really benefit women and the people that care about them.
Yeah, awesome. Okay. Take care, everyone. Have a good night. Bye.